Thanks, Joy, for the introduction. My name is Declan Soden. I work at the Cork Cancer Research Centre, and we have been working with electroporation, electrochemotherapy now since the start of the noughties, and we've enjoyed some great success with it. And I'm going to talk to you about the data from our clinical study looking at the treatment of basal cell carcinoma, which again you've heard some cases spoken about already today. Cork Cancer Research Centre is a translational research facility. It's a collaboration between University College Cork and the local cancer hospitals with very much a translational focus, and we became interested in the use of the technology of electroporation more actually in relation to immunotherapy and a desire or a research interest in the area of gene therapy and using electroporation. It's not something we're talking about here today, but an interest in utilizing electroporation to facilitate the delivery of DNA plasmids in. And that led, our interest in the space led to collaboration with other groups, Louise Mears' groups, Julie's group who spoke earlier on. We were involved with the initial ASOPE study, which Joy just spoke about in terms of kind of setting the parameters and the protocols for the technology, which I think has served us quite well over the last decade. One of the challenges as we have kind of worked with our local clinical community in terms of the use, the appropriate use of electrochemotherapy, one of the questions that came back to us from our plastic surgeons really was in relation to the 5-year follow-up on the use of electrochemotherapy, specifically in the area of basal cell carcinoma. So the question was, where's your level 1 evidence? Where's the evidence in relation to cure rates and recurrence rates? And so we decided a little over 5 years ago to do a 5-year follow-up study, a randomized study between comparing surgery, electrochemotherapy, and looking at response rates and looking at recurrence rates. The situation of looking at basal cell carcinoma, I think, is pretty much that there's not too much of a need really to focus on it, but obviously it's the incidence rate for it is increasing. We have a rate of about 1 per 1,000 in the population, which I think is equivalent between Ireland and the UK and largely across Europe also. Again, in terms of treatment options, obviously surgery is the gold standard. It's the traditional method for treating these lesions very, very successfully. There are other ablative technologies like radiotherapy treatment and so on. And therefore the question came in terms of the results we've seen for electrochemotherapy, the question being what sort of a role should it play in the management of BCCs. I think quite timely as well, the NICE guidance came out relatively recently, I think maybe 2013 or so, which was in favour in terms of the use of electrochemotherapy for primary basal cell carcinomas and SECs. But obviously we've lacked the kind of long-term follow-up, and that's something we were hoping to address in our study, and the hypothesis being what BCC in the appropriate circumstances can be effectively treated with electrochemotherapy. So that was our hypothesis, which we worked to try and prove. So for the study, these were primary BCCs, biopsy proven, no deep structural involvement, and these tumours were less than 3 centimetres in size. Again, I think as we just spoke a little bit about in terms of the kind of the appropriate size for the use of electrochemotherapy. Obviously, the patients were suitable for ECT, no contraindication in terms of the use of intravenous bleomycin. Patients were consented, and then the structure to the study was to follow up 3 months, 6 months, 1 year, 2 years, 3 years, and 5 years. So we've done all the 3-year follow-up, and we're actually halfway through the year 5 follow-up as it stands right now. So we're very close to the end. So for the study, we had 2 groups, electrochemotherapy or surgery. We had 233 patients assessed, of which 99 patients were enrolled. They were randomized. 52 patients entered the electrochemotherapy arm, 47 into the surgery arm. Ultimately, we lost some patients due to they dropped out after enrollment and so on. So ultimately, we ended up with 45 patients who were treated with electrochemotherapy versus 41 patients who were treated with surgery in the study. In terms of the demographics, largely similar age profiles and range, and so on. So quite a good mix in terms of sex and age. And then in terms of the types of lesions treated, primarily these patients had single lesions, although several of them did have more than one lesion which went on to be treated. And in terms of the subtype of BCC, they were treated again quite a broad range, but again evenly spread pretty much between the two groups. So for the patients that had electrochemotherapy, it was done under local anesthetic and some sedation, which is primarily the way we have conducted electrochemotherapy for most of our cases in Cork. In the case of surgery, there were 3 cases that were done under GA, and they involved flap resection. So we used bleomycin, again in the range that we've spoken about here today. The type of electrode we used primarily was the parallel, so these kind of 4 needles pair parallel apart, the linear array. 3 patients received the hexagonal system. In terms of the response to treatment then, so 86% of patients that received ECT had a complete response with 1 treatment. Some of those went on to have a second treatment, and those subsequently responded 100%. Similarly with surgery, 95% had a complete response with a single treatment. 2 patients or 5% required to go on for a second treatment, which delivered a complete response. So both groups, after a maximum of 2 treatments, demonstrated complete responses to all the BCCs treated. What we also did is we evaluated the cosmetic outcome comparison between the surgical group and the electrochemotherapy group, and we blinded the plastic surgeons who were involved in assessing the outcome, the response in terms of the parameters of color, contour and texture, and as you can see, the data demonstrated statistically there was no significant difference between the 2 groups. You've seen some of the data again from other cases from here locally that have responded, but by and large we have enjoyed pretty nice responses to the group of patients that were treated. So I think particularly from a cosmetic point of view, the patients have been very happy with the treatments that we received. So this is a lady, sorry, I should have mentioned this. This patient received electrochemotherapy, and you can see the response. And similarly here as well, again another case. Although you can see, I guess, in the case in the lower images, there is an indentation which is obvious post-treatment. Need to start again. So yes, so this is the data we have from 3 years. We're basically at a point now, we're at the 5-year follow-up. It hasn't changed significantly, but what has changed actually is slightly more in favor of electrochemotherapy insofar as since we did this 3-year analysis. One of the patients that we suspected of being a recurrence in the electrochemotherapy group proved false, and we have had an additional recurrence in the surgical group. So in terms of complete responses in the electrochemotherapy, we have 48 lesions at this stage, which are complete responders. We've lost 8 patients to follow-up. We have recurrences in 4 of the patients. However, sorry, that was at year 3. That's actually turned out to be 3 recurrences. In the surgery group, we have currently 34 complete responders, 10 lost to follow-up, and 2 with recurrences at this stage. So essentially, the 2 groups are showing largely equivalent overall responses. It's the same data presented rather than as lesions presented in terms of the patient responses. So by way of conclusion, At 3-year follow-up, we're quite satisfied that the data is demonstrating that electrochemotherapy enjoys quite a good complete response rate, quite a low recurrence rate, which is equivalent with surgery, and which our early stage 5-year follow-up would concur with, or certainly the trend has continued, and there's no significant difference between the recurrence rate between the two groups. So we would hope to publish this data before the end of this year. I'd also just like to finally just share with you as well, we have some other ongoing studies in Cork in relation to electroporation beyond this study. So we have a BMS-supported study of combining ipilimumab with electrochemotherapy in patients with advanced melanoma. We also have an endoscopic treatment for patients with esophageal and colorectal cancer with electrochemotherapy, which is ongoing. Phase 1 of that has just been completed between Cork and Copenhagen with Julie's group. And we have another device as well for lung thoracoscopic or laparoscopic delivery of electroporation. We're entering studies for that at the moment also. So I'd like to acknowledge these people and take any questions. Thank you.
Thank you very much.